Auzubillahiminash-shaytanir-rajim. Bismillahir-Rahmanir-Rahim. CME update by Mother and Child Survival Group of Pakistan. CME tips by Dr. Tariq Masood Khan, Obs Gynae Family Emergency Specialist, Gulf KSA, now being a district gynecologist. The topic for brief review is endometrial cancer. Endometrial cancer is also the most common worldwide cancers, especially having the risk factors. It's 22 over 1 lakh in America and 3.5 in 1 lakh in Africa as the difference in the risk factors. What are the etiological features of the endometrial cancer? It is basically a cancer of post-menopausal women. So any post-menopausal woman having bleeding PMB is to be sorted out for endometrial cancer, which have high chances of endometrial CA. The etiology is unopposed estrogens due to increased production of the estrogens, whether it is countered by the progesterone or due to increased production of estrogens in a number of conditions, endogenous and exogenous. And endogenous are granulosa cell tumors, polycystic ovarian disease, unopposed endometrial hyperplasia, and unopposed estrogen production. And then the exogenous are the tamoxifen and the other unopposed estrogens like HRT. Then comes the endometrial cancer is associated with obesity. Any disease with having increasing obesity like diabetes, hypothyroidism, and hypertension have increased chances of endometrial cancer. It also, pregnancy is a protecting effect, and PCOD, polycystic ovarian disease, and early menarche and late menopause. Then endometrial cancer, any post-menopausal bleeding suspiciously must be tried for investigation for endometrial cancer. Genetic lymph HP syndromes which have endometrial, ovarian, breast, and other colorectal cancer have genetic Lynch syndrome predisposition, in which there is a autosomal dominant inheritance of endometrial cancer in a repair inheritance page. Breast cancer is also belongs to cancer family syndrome, where this is very common, along with ovarian and colorectal and endometrial cancer. They are in a cancer family syndrome. It is a late age cancer. It starts from postmenopausal age, and then comes the types. The types of endometrial cancers are endometrioid, adenocarcinoma, clear cell or papillary carcinoma, and MMT, mixed Mullerian tumors. Then, for review of the symptoms, as I have told you, postmenopausal bleeding is the most important one, and also sometimes they are detected postcoital bleeding as well. They are also detected in smears checking also. And then the most important is the mass protruding from the cervix, and then there is increased pussy discharge with blood stained in an aged woman, in a post-women woman, is highly suggestive of an endometrial cancer. Sometimes the incidence is more than 50%. More than 50%. The presentation, the comorbidities, and the symptoms, symptomatology, drugs like RT, COCP, and oral hypoglycemics, antihypertensives, and others. And also family history and menstrual history, and the postmenopausal bleeding, and early menarche and late menopause. In the examination, we have to find out the rule out vulval, vaginal, endometrial, and cervical pathologies. And by doing examination like pap smears, cervical pathology is ruled out, and then comes the endometrial biopsy for this endometrial carcinoma, and the other investigations to rule out ovarian cancers and other genital tract cancer. And also, as I have told you, the breast cancer also has the genetic link with the endometrial cancer. And then investigations are most important is the endometrial thickness. If any thickness less than 4 millimeter, then it has unlikely chance, but any endometrial thickness greater than 4 or 5 millimeter must have been ruled out by endometrial biopsy. And also CT scan, chest, abdomen, and the pelvis, and the CXR, and urea creatinine, and LFTs and RFTs, and the bases, and especially the blood sugar also comes into these investigations, as the obesity is the main cause related to endometrial cancer. So then are the grading. This grading is high, well differentiated, moderately differentiated, and poorly differentiated, types already mentioned. Now the management of the endometrial cancers are that we have to have a gynecological oncologist and a multidisciplinary team with multi-speciality involvement, and especially the specialized centers. The important is to do a staging laparotomy, and then it is decided according to that what is going to the overall consensus is for the total abdominal hysterectomy and bilateral salpingo-oophorectomy. And then the role of pelvic lymph nodes is determined in the STEC, PORTEC, and in some Cochrane systemic reviews. So now the trend of increasing laparotomy, this increasing surgery through laparoscopic TAH and BSO are being done in great numbers, and has got less economic sanctions and less stay in the hospital and less complications. Then are the role of adjuvant radiotherapy and non-adjuvant radiotherapy has been compared in the ASTRAC trials. And then there is an adjuvant role of chemotherapy in the increasing grade of the invasions, which may be intermediate, early risk, high risk, and deep involvement, myometrial involvement, superficial invasion, and early invasion, superficial invasion, deep invasion, and in all these it has to be determined the role of these adjuvant and non-adjuvant radiotherapy. Their results have been compared in ASTEC 1, ASTEC 2 trials and in PORTEC. It has been determined in these trials that in low-grade disease there is no use of doing this pelvic lymph nodes radiotherapy to these pelvic lymph nodes, but obviously in higher than grade 2 and above and high disease, poorly differentiated disease and advanced disease, the role of neoadjuvant radiotherapy is clearly discussed and recommended. The new adjuvant chemotherapy has also been introduced as in for high grade disease, as there is no advantage, survival advantage in low grade disease of all these treatment modalities, adjuvant radiotherapies or neoadjuvant chemotherapies. Then in POTEC 3 trial also their role has been determined, but as said that there is no advantage in the low grade disease of no survival advantage in these low grade disease. So the total abdominal hysterectomy with bilateral sulfingophorectomy, pelvic lymphadenectomy, adjuvant radiotherapy, non-adjuvant radiotherapy, and non-adjuvant chemotherapy, all these have got and their roles have been determined in the ASTEC 1, ASTEC 2, and Cochrane's reviews, and in PORTEC 3 trials. So anything which any endometrial thickness greater than 5 millimeter must be ruled out with endometrial biopsy, and also sometimes this outdoor basis biopsies like pipella which can be done under local anesthesia, and also hysteroscopy under local anesthesia. But the endometrial biopsy can also be done in general anesthesia. Now a brief review of the staging of the endometrial cancer. First of all, it is in the early stages like 1, 1A, 1B, 1C. They are limited to the uterine body. Then in the next one they are gone to uterine cervix and stromas, and then to adnexa and to peritoneal cavity in the stage 2, and then in the stage 3 also to the peritoneal fluids, these adnexa and serosa and extension into the adjacent organs and into the lymph nodes. And then in the 3 stage it is already in the adnexa, in the lymph nodes, and in the serosa, and in the extension to the vagina and into the pelvic lymph nodes. And then in the 4th stage they are all involved the bladder and bowel, and then in the distant metastasis and also into the inguinal lymph nodes. So this is a brief review of the endometrial cancer. Anybody with postmenopausal bleeding or postmenopausal discharge must be investigated and ruled out for an endometrial carcinoma, which is very important and has got increased incidence with obesity and as due to unopposed estrogens. So in the endometrial biopsy, the findings could be a simple proliferative phase, a secretory phase, and mm, uh, then atypia, and there is uh, uh, atypical cells, and then last of all is the endometrial carcinoma. So these are the various ongoing normal histological features of the a normal endometrial biopsy, and grading and all these have already been mentioned. CT scan, chest, and all these modalities, imaging modalities, have also been described. So we'll come with another review, and takeaway messages: pray, praise, trust, love God Almighty Allah, and follow the Asu Hasna lifestyle of our Prophet. Durood Sharif on him and his followers, and our health and survival. And we must not forget our glorious past. Subhanallah wa bihamdihi, subhanallah al-azim, wa kufa billahi waliya, wa kufa billahi nasira. And then Allahumma zikrak shukrak wa husna ibadatak. And then we comes with the always we must consider, pray, praise, trust Allah, and also for everything, for every prayers, and for everything we need, we must ask. हम तो माइल बकरम है, कोई साइल ही नहीं. And our great glorious past, as mentioned, कि दो नीम इनकी ठोकर से सहरा और दरिया, सिमट कर पहाड़ इनकी हैबत से राय. Till that we come to an end with, and will proceed with another review shortly. Thank you very much. Best of luck. Wama alayna illal balagh, and goodbye and best wishes.